In Chapter 6, we are going to talk about the treatment of preschool children, and this is where the fun really begins. Most of my experience has been with preschool children, and this is such a fun age, and I enjoy watching the amount of growth overall and in their language. Again, the earlier we identify kids with a language delay, the quicker we can begin intervention. When they very first begin at this age, we will not know the difference between a delay and a disorder. At this stage, it will not make a difference in how we treat them. Research just shows us that we need to start early and get the child on the right track. It has also shown us the longer the child goes down the road of disorder, the harder it is to get them back on the road of typical development. You're going to see that I am not going to pause to tell you to watch videos. I did not find any videos in YouTube that I liked for this part. So I'm going to try to work with Clear starting early tomorrow morning to see if I can put some of my own videos from therapy up. I will note this on Canvas and tell you when to look at them in the PowerPoint. I'll note that on Canvas. Clear just has a lot of strict rules of we have to have closed captioning and different things like that. So that's kind of why they said go to YouTube first, because that already has closed captioning. So I'm going to see what I can do and try to get some things for you to watch up. First, we're going to discuss a few general considerations when working with a preschool child. First, let's think about why a child talks. Why does a child need to talk? Bottom line, they usually like it. It's just for their own pleasure. They like hearing their sounds. You'll hear a baby that'll just be babbling away, and it's not towards anyone. They also, of course, like to get their needs met. Then they talk, of course, because hopefully they like to interact with others. These are important to remember when you are looking at a behavior of a child in therapy. Thinking through these questions quickly in your brain helps you possibly understand a little of helps you understand a little of why they are doing what they are. Also, if they're not talking, then you can quickly try to think what you could do within one of these three categories to make them want to talk. We need to make sure that our intervention encompasses all three of these components. All of these components. First, we need to focus on the child. Their needs and their personality need to drive our intervention plans. We have to choose functional and meaningful goals. Our goals need to ensure that the child can function better in daily living situations. We also need to make sure that our intervention approaches are socially and communicatively meaningful. If a goal is next in the developmental trajectory, but it is not salient to the child, then we might need to skip that skill to work on something more meaningful and functional for the child. Next, the environment like the room we are in and the materials we use need to facilitate learning for the child. At the preschool level, family involvement is imperative. The therapist provides the target and strategies, but it is the family who is with the child 24 hours a day and practices those targets. Parent training is one of the most important part of our jobs with the preschool child, in my opinion. Besides knowing why the child might be motivated to talk, the clinician has to go in with a clear picture of the goal or purpose of intervention at that time. Remember on the first slide, I said that most of the time with this age, we are just trying to get them as close to typical development as we can. Here, um, here are the other two purposes of intervention. So why do we choose one over the other? Let's look at the three. First, we try to change or eliminate the underlying problem or etiology of the disorder. Intervention will make the child normal language learner. We will need one time or no other intervention if we are going to change or eliminate. The most common at the preschool age would be putting hearing aids on a child. If they did not have a language delay before and just putting the hearing aids on the child fixes their hearing and they're now back to typical, then we're done. That's the perfect example of that one. Second, we change the disorder where we attempt to improve the child's discrete aspects of language function by teaching specific behaviors. Here, we are working on aspects of the disorder, but there are still other aspects that are not typical. This is the most common purpose of therapy at this age because so many of our kids have a developmental disorder in that we do not know the etiology. If we know the etiology, then hopefully we can, or if we do know the etiology, hopefully we can do number one. If we don't, then we can't do number one. Third, we teach compensatory strategies, not specific language behaviors. They will always have some type of disorder, but this type of intervention focuses on decreasing the impact of the disorder on everyday life. This type of therapy requires cognitive maturity and more often seen in intervention programs with school-age kids and adults rather than this preschool age. Some examples include kids with word-finding abilities. We teach them word-finding strategies. Kids with dysfluencies, we teach them fluency shaping strategies. I do want to note that we often pair another focus of therapy with these three, especially at the preschool level. We want to make changes to the child's environment to maximize the child's potential. We will talk about some examples of environmental modifications later. So now we have the big picture of what we want to accomplish in intervention. Next, we're going to discuss how we choose what to work on. Our intervention goals are individualized to the child. Remember, evidence-based practice states that we consider the research, the child's needs, and the clinician's experience. We are going to take what we have learned from our assessment and let these three pillars drive our planning. From the assessment, you see where the child is in development along that developmental continuum. And wherever that child is, that's where you begin. If you have a child who is at a chronological age of 4 years old, don't look at what typical 4-year-old children do. Look at what that 4-year-old does. If that 4-year-old is still just using single words and maybe only has 30 words, what are you going to do? You're going to go back and teach them 50 words so they can get to the 2-word combinations. So wherever that child is on the developmental continuum, regardless of their age, that's where you're going to begin your therapy. And again, you want to make sure that they can be successful and functional in their environments. So you want to teach them things that they can use in their environment so it gets reinforced. When you leave therapy, you know that if you talked about something in therapy that never happens in their daily life, they'll forget about it. So you want to have something that they will use in everyday life. For preschool children who we hope just have a delay and not a disorder, we use the developmental approach, just how I mentioned earlier. The developmental approach is based on the normal language trajectory. We definitely have children who are not following typical language patterns, such as a child with autism or maybe a child with a syndrome. A lot of times, children might have a lot of skills in one area, but low skills in another area, and we see larger gaps in functioning. This can affect what we decide to target in intervention. Like we discussed earlier, your assessment drives your intervention. We are going to take the strengths and weaknesses from the evaluation to give us a list of what needs to be a target. We are going to pair them to the normal developmental trajectory. Now what happens if there is a list that has about 20 different things on it? Can you focus on all 20 skills at the same time? Of course not. These other parameters are going to help us prioritize those 20 skills and help us focus on what to target first. We have to consider the child's zone of proximal development. This is the term tagged by Vygotsky, which is the distance between a child's current level of independent functioning and potential level of performance. This defines what the child is ready to learn with help from a competent adult. We do stimulability tasks in the assessment or in the initial therapy sessions to help us determine how much the child can do with different kinds and levels of assistance. Of course, as already discussed, we look at the environmental demands and prioritize the skills by functionality. What skills can I target that will make the child more functional in their environment quicker? One perfect example for this is when I might add augmentative communication goals to the plan of a child who is nonverbal. If I can get them to be a more functional communicator using pictures while I am working on verbalizations, then I'm going to most certainly do so. This is also a reason why many choose total communication for those who have a hearing impairment. Total communication hits all modalities of communication. All children are going to have strengths. We want to use those strengths to support their challenges. Can you think of any instances? How about the child who is a visual learner but not an auditory learner? What could we do to help them? Think about this. I'll give you a second. One thing I think of is using a visual schedule to help the child transition and be more independent in carrying out the tasks. Also, we might pair pictures of items with the verbal production to help them learn new words. Lastly, we need to consider the teachability of the target. Which forms are more teachable? Here is the list of targets that are more teachable. First, those that are more easily demonstrated or pictured. Second, ones that are taught through stimulus materials that are easily accessed and organized. Number 3, those that are used frequently in naturally occurring everyday activities in which the child is engaged. Now we are going to look at common intervention targets at this preschool stage. The big picture goal in preschool intervention is to take the child from being born, having them interact with their world and others, to having oral language. Well after the preschool years, we're going to want well-developed conversations and narratives. So the focus of language intervention for each level, we're going to of course start with the infant and toddlers, so birth to 3 years. So of course intervention should be family centered at this age. Like I said earlier, they are with us for about 2 to 3 times a week for an hour, but they are with the family 24 hours a day. So we teach the family what we want them to work on while we're not there. So some focus are development of functional and symbolic play and gesture, use of intentional communicative behavior, so of course pointing, turn taking and imitation at this age, and then language comprehension appropriate for where they are at their developmental level, production of a variety of sounds and syllable structures, production of words and word combinations. So early childhood intervention, inpatient, outpatient hospitals, private clinics, and home health are the primary settings where we're going to see this birth to 3 years. We can also see them in the schools No, not at the schools, at the birth to 3. Just kidding. Schools start at 3 years. Now we can go to the schools, and when they are in the preschool age, 3 to 5 years, our intervention should definitely still be family centered. Public school, here we go. So there is public school programs for the preschool age. And then the inpatient, outpatient hospitals, private clinics, and home health agencies are again those primary settings where we see this age. So our focus here is help the child acquire intelligible, grammatical, flexible forms of expression for the ideas and concepts. Give the child the tools to make communication effective, efficient, and rewarding so that social interaction proceeds as normal as possible. And third, provide the oral language basis for success in literacy. So remember, we're going to try to plan our therapy to follow typical development. So before 12 months, we are going to focus on those pre-linguistic skills, also those more known as those social interaction skills. So are wanting to instill in them just the love of interacting and communicating with adults. We're going to focus on those early communication, just back and forth turn taking skills that will be important later when we want them to turn taking conversation. Then, of course, we want first words and building that lexicon. So we want to definitely have a variety of words and a variety of categories. So nouns, we are going to teach the nouns within categories. So we're not going to be random and just teach them this noun, that noun. We're going to go, if you remember in your language development class, you learned the different types of categories of nouns that are learned earlier. So our animals, our toys, our things that are salient to them, like their bottle and their cup, their blanket, personal types of items. And so, yeah, so we're going to stick within these different categories and teach vocabulary within those categories. Then we're going to, of course, teach a variety of verbs, spatial concepts, and quantitative concepts. Then we're going to work on those two-word combinations. We want a variety of semantic relations. Again, going back to your language development class, we're going to want like attribute plus entity, so big shoe, possessor plus possession, so mommy's nose. And then agent action is another example, like doggy run or daddy run. Then, of course, is our simple sentences, so our 3+ word combinations. And then after that is conversations and narratives. And do we get to conversations and narratives by 5 years of age? Of course we do. Now you have the purpose or goal of intervention and what you want to work on set. Now you have to plan the intervention sessions. They can look very different based on the client and the types of goals you're working on. All clients, but especially preschool children, are very dynamic. Before beginning intervention, you need to consider some personal characteristics of the client that will affect how you plan for the session. These include the activity level of the child. So this is the degree to which the child moves around or needs to move around to keep their attention where you want it. The rhythmicity, I hate that word, sorry. The child's regularity with regard to sleep patterns, eating, and bowel and bladder functions. If you have a kid who doesn't sleep well, you are going to get a kid that comes to you different nearly every day. Especially my kids with autism, they often have very random sleep patterns. And I would have this one child come in and he would be different nearly every day. And my first question is I would ask how he slept that night. To give me kind of an idea of what kind of day we were going to have. Then the next is approach or withdrawal. So this is the reaction of the child to any new stimulus, including people, food, and places. So are they going to just easily accept these new things, or are they going to withdraw a while? And it takes a little while for them to get used to it, and then hopefully they will. Yeah, you just kind of have to learn which one your child is. Then the adaptability is the child's ability to adapt to new situations, even if the initial response was withdrawal. So, are they going to be one of these kids that takes a while to establish rapport with a therapist? So it's maybe not smart to change therapists on them very often. Then the intensity of reaction. This is the child's tendency to scream or whimper when hungry or laugh, smile when amused. But are they just kind of a mild-mannered, go with the flow type of kiddo, or is our emotional regulation a little off? That we're just a little too reactive. Threshold of responsiveness is the degree of sensitivity to environmental stimuli and to changes in the environment. So if we have a low threshold of responsiveness, that is the kiddos that you could have a fire alarm going off and they're like, doo doo doo, still playing with my toy, whatever. And then you have these kids that are hypersensitive to what is going on in the environment, and maybe any little sound, like in the next room, just distracts them and they can't focus. The next is quality of mood. It's the child's overall disposition, whether they're pleasant and friendly or they just always a little grumpy or unfriendly. Distractibility, the ease with which the child can be interrupted in an ongoing activity. So yeah, how distractible are they? And then the attention span and persistence, the length of time the child can pursue an activity or persist despite interruptions. So a part of that attention span is how quickly will they regain attention to an activity also. Besides the characteristics of the child, your efforts are going to not be as effective if the child and the family or the caregivers, if you do not have rapport with them. This takes time to build this level of mutual trust. If the clinician pays attention to these elements, rapport should definitely build. So respect. The clinician must hold in mutual regard the child and the family, and the clinician play in addressing the communication deficit. So there needs to be respect of the family and the child, but then gaining that respect of you also. Admiration. You must hold in esteem the family's effort to facilitate language and communication in their child. You really need to really give them kudos for working hard and doing things that they are doing well. Because a lot of times we talk about what they need to change, but not what they're already doing well. Participation. Develop a therapy program that empowers the child and the family to be active participants in the process. Professional interaction. Maintain a professional yet personal level of interaction with the child and family. You definitely have to set boundaries. So definitely, I think a very common one between clinicians is that on social media, we are not going to interact with our families on social media until maybe they are no longer on our caseload. That is always one of my favorite things when I can friend a mom on Facebook after we're done with therapy so I can see what the child is doing. It's always nice to see that. Opportunity to go with the flow and take advantage of situations that present themselves in accordance with the therapy procedures and goals. And then restraint, to be less directive and more accommodating of the child's language and communication efforts, thereby encouraging active participation in therapy. And lastly, thinking about timing, to be cognizant of the family's readiness to receive and accept the fact that their child may have a communication deficit. Now we need to look at choosing an intervention approach. With the preschool child, we really need to look at the continuum of naturalness. So we have on the left, we have our child center models. Then on our far right, we have our clinician directed models. And then in the middle, we have our hybrid models of intervention. So the child-centered daily activities are following the child's lead. So this one is it sounds very easy. This one is play-based, and we are just following the child's lead, and we're facilitating their language while we play. Like I said, it's really harder, easier said than done, because you really have to think on your feet. So it is to be truly child-centered. The clinician is not manipulating the environment in any way. So you go into the home and you just whatever the child wants to play with, you play with. You're not bringing in any different toys. It's just whatever is there in the natural environment. With the clinician directed, this is like it says, the clinician is planning really every aspect of that therapy. They are deciding what are the activities that are going to be used to work on those targets. What are the stimulus items that they're going to use to elicit those targets? What's going to be the order of therapy? So really everything is planned by the clinician there. Now, hybrid is again somewhere in the middle. We definitely have some that of the child-centered hybrid approaches that are barely off of child-centered. Uh, but they do go in the hybrid. And one perfect example is if I'm maybe a home health therapist, but I bring in my own toys because I know that these toys can elicit the targets a little bit easier than just having, you know, just going to any of the kids' random toys. Or if I know that the child is going to be more motivated by using some novel toys and not the toys that are in their everyday environment. So as soon as I manipulate something as easy as what toys are going to be available to the child, now, I'm not telling him exactly what to do with them, or I'm still following his lead while we're playing with those toys, but I did manipulate it some and bringing in certain toys. As soon as I do that, then it's gone to a hybrid approach. So to be honest, there is very few instances of doing 100% child-centered, but definitely it's out there. But most of the time, you have a hybrid approach that is very, very child-centered. Um, but the hybrid often will target one or a small set of specific goals. And the clinician maintains a good deal of control in selecting the materials and activities, but does so in a way that consciously tempts the child to make spontaneous utterances. And then the clinician uses linguistic stimuli, not just to respond to the child's communication, but to model and highlight the forms being targeted. So those three things often happen in the hybrid type of approaches. So, some more information on child-centered, and then we'll get to the clinician-directed. But a common approach in the child-centered is indirect language stimulation. So, this is when the clinician arranges the environment so opportunities for the child to produce the target occur as a natural part of play and interaction. So again, if the clinician arranges the environment, we are child-centered, but we're into a hybrid child-centered approach. The clinician embeds the intervention strategies into natural play activities, and then the clinician just follows the child's lead. So this is play-based therapy to a T. So in this child-centered intervention, we are going to use certain different types of strategies. This isn't everything. You'll learn more in graduate school, but this gives you a good idea of some of the strategies you're going to use during those very play-based interactions. First, we're going to use self-talk. So this is when we describe our own actions. So when I'm playing with a child and we're sitting down and I said, oh, look, Miss Lauren has a horsey. This horse is running around. And of course, I'm making the horse run around. And then the horse decides that he wants to get a drink of water. I might say, look, now the horse is over here drinking water. Nom, nom, nom. Oh, yummy water. And then the horse might go, I'm going night night. And of course, at that point, I'm putting the horse to bed. So and then he goes to sleep. So simple sentences, but I'm describing what I'm doing. Then parallel talk is when I'm providing self-talk for the child. So I'm sitting next to the child in the so I'm not talking about myself, but I'm talking about what the child is doing. So if he is holding the horse and makes it run, you could say, oh, look, the horse is running. Oh, the horse is jumping over the fence. So just as the child is doing something, you are narrating it. So you're describing what the child is doing. And you're not asking the child to answer any questions. You're just narrating what they're doing. So that's why it's called indirect. You're just providing the model so that the child is not required to respond. You hope the child will imitate you in response, but again, that's not a requirement. You're just providing the model. The next is recast. It's when the child says something and then you say something and expand on it. Now, there's definitely more than just a recast, and we're going to talk about those in a second. So those is when we're going to increase the semantics or we are going to model correct grammar. But let me do this to help explain a recast. So let's think about the analogy of fishing. So when you go out to a lake and you're fishing, and you have a child with you. And the child throws the lure out. He casts that lure out, and it's not so good, of course, and it doesn't go so far. So you come back and you help the child, and you hold the child's arm, and you help the child to recast so that they can get out something that is much better. So that's what you do with this language. When the child says something, throws something out there with his words, then you provide the model for more words. So if the child says color, color book, then you could say, oh, you want to color? You want to color the book? Again, you don't want to make it too long so that it goes beyond what he understands, but you give him something to say that's better. And there's some other things you can do, like dog bark. I would say yes. So the kid says dog bark, and I could say, yes, the dog is barking. And I might repeat it 2 or 3 times. It is not focused specifically on modeling the grammatically correct form of the child's utterance or adding new semantic information, but more just to take a turn in affirming the child's utterance. You can also change a statement into a question to recast their utterance. That is very common. So imitations are when you just repeat what the child says without expanding on it or anything. So that's another way for the child to be stimulated again to hear what they said. So some other ones are expansions. So this one, we take the child's utterance and add grammatical markers and semantic details that would make it an acceptable and correct utterance. So if the child says, baby eat, you could expand it to, yeah, the baby is eating. On the extensions, these are comments that add some semantic information to a remark made by the child. So if the baby said, or if the child said, baby eat, you could extend it to, yes, the baby is eating yummy grapes. So the semantic information that I added there was obviously yummy grapes. Then build-ups and breakdowns are something that I use all of the time. So this is when you take the child's utterance and build it up to a more correct form and then break it back down again. So if the child says baby, then you go, yes, baby. Baby is eating. Baby is eating grapes. Yeah. Baby is eating. Baby. So do you see how I took their baby, then I added the baby is eating, then I added baby is eating grapes, then I went back down and said my other utterance and said baby is eating, and then I ended it with baby. So taking what they gave, building it up so they can see how the words come together, but then I'm going to break it down also. So with these indirect language stimulation techniques, remember, we definitely use contingent feedback, okay? So it is really based on what the child is doing, knowing what the goals are that we're wanting to focus on, use those different indirect language stimulation techniques um, to facilitate those goals that you're wanting. Then we use definitely balanced turn taking. So what I work on with students in the clinic all the time with child-centered intervention is, and parents, definitely parents, is the adult just talks way too much. And the adult just narrates everything, but never gives the child, never pauses and gives the child time to imitate or time to initiate something. So we want to make sure that, you know, if we take a turn, we give them definitely a turn. You know, they might not do something and we have to take a turn or maybe two, you know, before they will take their turn. But we just have to really watch that we're not talking too much. And then definitely using those extensions of the child's topic to kind of keep them interested and staying kind of step ahead of them. It's very helpful. So remember also that we use language just above their level when we're modeling for them. So I thought it'd be fun to practice in identifying some of these indirect language strategies. So take a second now to pause the video and label which indirect language strategy is being used. Then come back to the video and we will discuss. So this first one, the child says dog and the clinician says big dog, white. Big dog, dog. Okay, so then this, of course, would be a build-up breakdown. So we start with the dog. I should have written there, sorry, dog, then big dog white, big dog, and then dog. Then the child says for the second one, baby bye-bye. The clinician says the baby is going bye-bye. This is an expansion. Then the child says, bottle, and the clinician says, bottle. This is imitation. Just be kind of reaffirming that the child is saying the correct word. And then the clinician narrates her actions while playing with the horse. Of course, that's self-talk. And then the child says, baby bed. And the clinician says, is that a baby's bed? And then that is a recast because we recasted it into a question. Now we're going to go and talk about the clinician-directed intervention. And again, this is where the clinician really plans every part. As you see in this picture, this is pretty common. Sitting more at a table, having just one activity out, okay, sorry, something just happened with my computer. Okay, so we use these clinician-directed interventions used to initially teach a new skill. So we have three types of clinician-directed. We have just drill, we have drill play, and then we have modeling. So drill is when I just have a stimulus, the child gives me a response, and I reinforce it. To be honest, I never use drill with the preschool age. I really don't use just drill, even with my elementary school age. Most of the time we're using drill play. So drill play is when you put this drill, so the stimulus, response, and reinforcement, but into a fun play-based activity. So some examples could be maybe you just get a board game and you have a picture card and they say the stimulus that they're wanting. So maybe you're working on prepositions and it's a picture card of a ball on a table and they have to say on. And then they get to go play a turn it at the game, at the board game. Or, really way more play based even is for these younger ages would be like I might give them a flashlight and we go on a bear hunt and maybe or an animal hunt. And so we want to spot the bears or all the animals. And so maybe we're working on animal vocabulary. So we've done some play-based things where we've played with the farm. Now I want to take it out of context a little bit and see if they can just name the animals. So I turn off the lights and I would have the child find a picture. They would tell me what the picture is, then go put the picture in a bucket. That would be drill play. The modeling is when the child watches a third person model the desired behavior. So then the clinician asks them to do the same task. So this one, when we are in the UNT Speech and Hearing Clinic and I have the student in myself, then modeling is really nice. We are able to do modeling because I will, kind of pretend like I'm teaching the clinician how to do something. And then I'll go do that same thing. So they model the correct behavior, and then I'll go do the same thing with the child. So one thing I wanted to say also about drill play is that drill play really adds in the motivation and the fun of being there. And again, with kids, you just want them to think they're playing and having a good time and not thinking that they're doing a bunch of work. So the clinician directed our purposes. We are going to again discuss the opposite of the clinician of the opposite of the continuum there. So the purposes of this is make relevant linguistic stimuli salient. Okay, so by giving a stimulus item, and so like a picture or an object, then I am really isolating that concept or that picture or whatever it is. Whereas if you're just play-based and you have, a toy with lots of different parts and things like that, they don't know as well sometimes as what you are focusing on. But clinician directed with your specific stimuli, it definitely does. And then it reduces or eliminates irrelevant stimuli. So I think I just explained that too. Besides just helping them focus, they know exactly what is important and what they don't need to pay attention to. And then it provides clear reinforcement to increase frequency of the desired behavior. So again, clinician directed is I give them a stimulus, so a picture of an item, they respond, so maybe they name the item, and then I reinforce in some way. It might just be a verbal reinforcement of, oh yes, that is a dog, to I really like that work. Your work here, but that's not a dog, that's a cow, something like that. And then, clinician directed environment allows the clinician to control the environment so the intervention is more efficient in changing the language behavior. So some of the different clinician-directed techniques are physical assistance. So they will, so in the stimulus response and reinforcement, in our reinforcement or when we are giving the stimulus, kind of either one, we can give them some type of physical assistance, like showing them a picture or maybe, holding their mouth in a certain way to help them make a sound or something. Modeling and imitation, of course, providing a model and having them imitate it. Shaping is when they give us a behavior and we are going to do something to shape their behavior closer to the correct behavior. So if they say a certain sound, you might do something of changing something just a little bit about that sound to shape it to make it sound a little bit closer to the target sound. Cueing is when we give them a cue of when we want them to respond. Okay, it has nothing to do about the quality of the response, but when we want them to respond. So that's just giving them, maybe a lead-in sentence or a carrier phrase. You want and they say toy or something like that. So I'm cueing them of, hello, I want you to respond now. Prompting or verbal instruction is that teaching, like what exactly are you teaching them? And the prompting can be, it's a part of shaping, okay? So if you're thinking they're very close, they are very close. And so we will use prompting and cueing within shaping the behavior. Chaining, and that's putting a sequence of behaviors together. So if I want them to do like a 3-part command, I might teach them, or a 3-part sequence, I might teach them the first part in isolation, the second part, and the third part. Then I might chain the first and the second part together, and then the second and third part together, and then 1, 2, and 3 all together. Fading is very important with all of these, okay? So all of these are ways to teach, and I want to fade my teaching over time as they get a skill. I want them to become more and more independent and spontaneous in producing that skill. So we did already kind of talk about hybrids. So those are the models that are going to have aspects of each. And you can definitely be a hybrid approach that's closer to the clinician directed, or a hybrid approach that is more the child centered. So remember, as soon as the clinician manipulates anything in the environment, then the child focused model has really turned to a hybrid. So what do you think? Is one approach better? And then are you wondering, how do we pick one over the other? So think about this for a second. Well, hopefully you're thinking one is not better than the other. It just depends on the child's needs and their personal characteristics. If a child is not going to sit at a table and do an activity that is planned out, or we are just trying to get them to talk, but not work necessarily on any specific language concept, then Child Center might be chosen. If you're really needing to teach a specific skill or concept, then having specific stimulus items already picked out that teach the concept might be the best, and this would be clinician directed. So you have chosen the intervention approach and have some broad strategies for intervention. Now you need to plan the specific activities and elicitation techniques you're going to use with the child. So there are three stages in developing new skills. First, when we're thinking about changing how someone is doing something, So big picture, when we're thinking about changing how someone does something, we need to think about these three stages of skill development. Sorry. First, a person is at the cognitive stage or the acquisition stage. The skill needs to be introduced in multiple ways and multiple times. We are first going to give a lot of assistance and then decrease our level, like I said earlier. Extrinsic reinforcers are often needed at this stage. Second is the fixation stage or the proficiency stage. In this stage, the therapist is going to stabilize skills in the therapy environment. We're hoping that the child has received positive reinforcers from producing the skills. Excuse me, so we now have some intrinsic reinforcement occurring. The third stage is the autonomous stage or the maintenance stage. This is when skills are going to transfer to other environments. Sometimes we have to do direct work on this generalization of skills, and sometimes it's more naturally occurring. So obviously, the clinician is going to begin at the cognitive stage when working on a new skill. When we are first planning the session, we have our therapy goals or targets. Now we need to figure out how we are going to work on them. First, we need to figure out the activity we are going to use to work on the goal. We need to make sure that we choose a variety of activities within a session to make sure that we keep the child's interest. If we do the same thing each time, most kids are going to get bored and they're not going to want to come to therapy. Now, there's always an exception to that, but generally, as a rule, if you plan interesting activities and stay ahead of their motivation and their interest level, the better. So, with any intervention approach you use, you need to choose from this list. So, books and magazines. Magazines would be probably for the older, but books for the younger. Crafts, of course. You can think of crafts that even the boys like. And then homemade games. So those are games that you're going to make yourself. So the flashlight game, like I said, is something that I just made up and did myself. Maybe I'll do like a beanbag toss. So we toss a beanbag. I've done a go fishing game, so I'll put the pictures on a fish and make a little fishing pole out of a magnet. So these are all things that I've made up in the materials I've made up myself. And then the published games are like the board games, the stuff that's out there that they just take a turn with the game. And then cooking and food. I think people forget this one a lot. And of course, you have to ask the parents about what food the child cannot, and can have. But cooking and food is a great activity. And then just toys. Of course, we're going to definitely bring in different toys with this preschool level. And then so that's the activity. So within our activity, we have to think, what is the stimuli? So of course the stimuli this is more going to be in the clinician directed. So pictures, you heard me say pictures, toys, they can be real objects, or definitely we can use computers. So there are definitely some great apps, computer games that will have the stimulus items or the concepts that you're working on. And so that's just another great thing to throw in there. So, we have kids and they are definitely going to have behaviors. So, some strategies that you can use that are going to help, I always say be proactive and use some proactive active strategies so we don't even have behaviors. Sometimes definitely we have to be reactive and react to bad behaviors and shape those into better behaviors, but some of these definitely will help you be proactive. So the first one, of course, is letting the child have a say in the order of the activities. Um, so you have planned out what you want to do, but you kind of could care less what order that you do it as long as you get to the 4 different activities, which maybe represent 4 different goals you're trying to work on that day. So if you just have the items out and let the child pick, they think that they're in charge of the session, and but they're not. But if they feel that way, it's good. That empowers them. And then the use of visual schedules in which the child can see all of his options, and then he picks the picture of the activity off and then has to pick another activity the next time is definitely a help. Um, even if you can't let, for some reason, the child pick the order, a static visual schedule is good because it lets the child see what's going to happen that day and then also when the end is. Okay, that's really important. So if I had a static visual schedule, then maybe I had my 4 activities on that schedule. I might let them put a sticker on the activity as we're finished so they see, look, I only have 2 more activities than 1 activity. Even if they're having a good time, it helps them kind of see the end. And then next, if you ask a question to a child, you have to be ready to follow through with their answer. So if you ask, do you want to? And they say no, then you have to be prepared to not do that thing. So this is a hard thing to do. It takes a lot of retraining when you're first starting because you will ask them, and there are very nice ways to tell them and get them excited of, oh, today we have we're doing 4 very fun things today. And you know what? Here they are. Tell me which one you want to do first. Instead of, yeah. So, asking if, hey, do you want to do this? And they're like, no. And then you go, do you want to do this? And they say no. And you've gone through all 4 of your things. And so you're in trouble. All right. So lastly, you have to decrease distractions. This can be things in the room or things that the child has access to. For example, have only one item out at a time or one activity. So if you show him the 2 activities and he picks A, put B out of sight so that the child won't be thinking about B and will work just on A. You also have to think about what you have on the table with you. If they're really busy, and I call them grabby hands, if they're one of those kiddos, then maybe instead of having all the crayons out, you keep the box in your lap, and then when it's time to pick another color, then you give them the box versus having a whole pile of crayons on the table that they can totally mess with and put them on the floor and all that good stuff. So now, and we've talked a little bit about this, but you need to think about your interaction style as a clinician. So we have to modify our language when we're talking to the child. So ways we do this is, number 1, reduce our rate. Number 2 is repeat your utterance. On the first repetition, keep it the same. On the second repetition, slightly change the language a little bit. And on the third repetition, model or give hand assistance as you repeat the utterance. Third, we use stress to highlight important words, of course. Decrease complexity of your utterances to be slightly higher than the child's. And then use comments and statements, not questions. Don't ask again if you don't want the answer to be no. So we definitely have to make every interaction meaningful and salient. So if two intervention approaches are equally effective in teaching a skill, choose the more naturalistic activity. Make your language informative and contingent on the child's actions and verbalizations. Always seek ways to increase the child's internal motivation to work on the task. And then use cohesive text. Child with will relate and remember a skill more if the series of utterances are syntactically related or also semantically related. So establish a topic of conversation and then elaborate on it. A girl is running. She is running fast. She wins the race. So then remember the continuum from here and now to there and then. Plan activities that bridge this gap. So with younger children or first teaching a skill, use techniques that target the skill using object and events in the immediate environment. Later build in actions that convey the skill to convey new information about things that are not present in the here and now. This teaches that they can use communication to impart information that is not present in the immediate environment. So an activity could make some type of food and then have the child retell the parents what you did with the correct target when you go to the waiting room. So for our last slide, some implementation tips to leave with. Remember to maximize responses from the child, not the SLP or activity, and provide enough support for success, but always fade. And then one new thing at a time. Teach something new in something familiar. So think about things. So teach something new and something familiar. So if we're going to teach a new concept, let's do a familiar activity and then in our familiar concepts, but then build in that new one. And then make use of every minute. So definitely having your materials ready, having them organized in a way that you can access them quickly, because think about kids who have downtime. What are you going to get? You're probably going to get some behaviors you don't want. So the least amount of downtime you give them while maybe you're transitioning to different activities, the better. So we are done with chapter 6, and this lays the foundation for any of the other intervention chapters we're going to talk about. So yeah, all right, see you next week.